Good morning. Welcome to our CU session on series of critical appraisals. So today we thought we'll take a break from the series of AI lectures, and today it will be a topic on the use of PRECIS-2 tool. So we'll have Dr. Feneeshiah, consultant in general medicine, who will give an overview of what pragmatic trials are and also critically appraise randomized control trial to see how pragmatic it is using this PRECIS-2 tool. Over to Dr. Feneeshiah. Thank you.
So good morning, everyone. Today we will be looking at evaluating the pragmatism of a clinical trial using the PRECIS-2 tool. So moving on. So how does our the evidence we synthesize in lab come to clinical practice? So first of all, there is a basic science research where the biology and the mechanism of action of a potential treatment is studied using various laboratory studies, animal models, and preclinical studies. And if there is an potential treatment which is found, this is going into phase 1 and phase 2 clinical trials where they are tested on healthy volunteers to know the safety and efficacy of the intervention. If they are proven to be safe and efficacious, they move on to phase 3 clinical trials where they are tried on actual patients with the real control data. So as to ascertain what is the maximum efficacy we could probably ascertain from the potential treatment. So does all of these efficacious methods actually work in clinical practice? So that is dependent on multiple other factors. So to see the effectiveness, we go to phase 4 clinical trials. And this is where our pragmatic clinical trials come in to see how much of the intervention is actually effective in our clinical care. Then moving on, in clinical practice, we identify the gaps which is there in already existing treatment. And further, this process continues. So our pragmatic trials usually take their place in the implementation research where the effectiveness of a certain intervention is looked at. So what is pragmatism? Pragmatic means which is very practical or close to real world. So while looking at pragmatic trials, these are done on with the real world noise, with the not so efficacious surroundings. So the effectiveness of a particular intervention or a medication is tested on the real world data in case of pragmatic clinical trials. So what are pragmatic trials and what is the other one which is explanatory? Let me take you with an example. So suppose you're going to buy a new car. So the car dealer gives you all the specifications as in what all will you look at. So they tell you the mileage is around 24 kilometer per liter. You're happy with it, you buy the car. The next week you go on for a long drive. And then you realize what you get is somewhere around 18 kilometer per liter. Did the manufacturer actually give you some fake values? So where they have looked at this 24 kilometer per liter is on when the car goes in smooth tracks with no traffic, there is steady speed, ideal tire pressure, the load is very controlled, no AC. And when you're going for a long drive, there are traffic jams, there is stop and go driving, there is AC which is on. Then there are so passengers and sudden braking, and then there is weather variation. So how effective is the energy efficacy of the car will give you what is an explanatory design, which is very controlled. So what actually happens in the real world with all the real world noise is a pragmatic approach to this. So talking about explanatory approach, it's like driving in a controlled racetrack where everything is fine and your car model is also fine. And while talking about pragmatic, it's like driving in Indian roads where you're not sure how the road is. So translating it into our clinical thing. So for an example, while talking about antihypertensive drug, does drug A actually reduce your systolic blood pressure? You can try it in explanatory design as well as pragmatic design. So explanatory design is, will it really work? So in an explanatory trial design, when you're including the participants, you strictly include this particular age, 40 to 60. I will exclude all the elderly, all the young ones, all the vulnerable groups like pregnancy, children, all of them will be excluded. And we set a specific baseline blood pressure around 150 to 160. And we select the participants who fall only when they fulfill all this criteria. And the ones with comorbidities and with reduced life expectancy, all of this population is excluded. And the way how they are recruited is through a tertiary care setting. And they have a strict scheduled follow-up visit, and whatever medications they are taking is also tightly controlled, and whatever extra medications which they require is also streamlined. Whereas when we look at the pragmatic design, so this this pragmatic structure will include as much participants who are eligible as possible. For example, they may not exclude vulnerable groups like pregnant women or adolescents. So the patients with multimorbidities and with the chance of an adverse clinical outcome, all of them are included irrespective of what they are. And the recruitment mostly happens in their usual care setting. It may not be in a tertiary hospital or a teaching center where the studies are usually done. This will be in the community setting as such. And the follow-up also, they need not come more than what is frequent, more than what is in their usual care. So, and the data is mostly collected through electronic health records without affecting the usual structure and follow-up of this patient. So what is the problem with this? Explanatory designs are very good in assessing how good the possible intervention can work when everything else is normal. So all this study design has like maximum internal validity. Whereas when you look at the pragmatic design, this is closely mimicking a real world scenario. Actually, it includes the real world noise. So there is more generalizability and external validity as such. So first, for any intervention X, we say, can this treatment work under ideal conditions? This is more of an explanatory question. Does this treatment actually work in real world practice? This is a pragmatic one. So what is the problem? Why are the treatments which are like proven in a randomized control trial does not work in the real world as such? So in a explanatory RCTs, there is strict inclusion exclusion criteria. So almost the participants who are all enrolled are almost similar in the baseline characters. Whereas in the real world, there are a lot of differences in terms of age, in terms of their comorbidities, and in terms of pharmacogenomics and how they respond to treatment as such. So when you look at a controlled RCT, which is an explanatory type, the treatment effect would be much higher than what is expected on a usual basis. Plus, we cannot always make sure that the patient has been compliant on everything. So the factors which affect the compliance would be sometimes the patient would be forgetful, sometimes the medications would not be available, and sometimes there are other factors like the neighbor would have told this medication would not work and the patient would not take. So with all of that noise, how much is the treatment working? That is what has been looked at in a pragmatic design. So there are two terms like real world evidence and real world effectiveness. Real world evidence is the one which encompasses the data which is derived analyzing the real world sources outside of the highly controlled clinical trial setting. Whereas real world effectiveness is that how well an intervention performs compared to alternate standards under typical healthcare condition. So how do these differ? So explanatory clinical trials will have the strict eligibility criteria. So the patients with multiple comorbidities who have possibility of an adverse clinical outcome, all of them are excluded mostly. And the intervention which is given is as per a strict protocol, and the additional procedures and processes are compared to standard, and they are conducted at a specific institution which is known to organize these complex trials. And there is extensive data collection, and the endpoint targets a scientific knowledge and understanding of the disease process. Overall, they have limited external validity because the data and the setting in which the particular data is obtained may not be representative of the condition in the day-to-day practice. Whereas in a pragmatic trial, there is wide inclusion criteria. As much as the population who are under the particular disease are tried and included, and the procedures are as per standard practice. So the interventions are made sure that they are more towards the usual setting and nothing additional is there. And they are conducted in the community hospital. They need not travel to a tertiary center or a quaternary center to get the intervention as such. And the data collection is to the relevant markers. So they are not followed up very frequently. There is no structured, more frequent follow-up to capture as much as data as possible. Then the endpoints direct a clinically relevant question. So, for example, when we look at antihypertensives in lowering blood pressure, a pragmatic trial would look at something like a hard outcome like mortality benefit, whereas an explanatory design would see how effective it is in reducing the blood pressure to like 20 to 30 millimeters of mercury by around 3 weeks. So that was one of the difference in the endpoint they look at. And this have good external validity because this closely mimics the population whom we might have to provide the care for. So this has good generalizability and external validity. So looking at the pragmatic trials, to assess the level of pragmatism, there is PRECIS and PRECIS-2 tool. The upgraded one is PRECIS-2. So this has 9 domains in which they assess how close the concerned trial is to the reality. Like, so for example, when we look at eligibility, they make sure that whoever is eligible for a certain intervention under the certain disease process is included to the trial. So the vulnerable groups like pregnant women, adolescents, they are also tried to be a part of trial as much as possible. The recruitment, they look at how much extra effort is made to recruit the participant. And a pragmatic approach would be to recruit the participant at the point of care itself and not an unusual setting. And the setting is how the settings of the trial different from the usual setting. Like, for example, if I were to do a trial on hypertension, the usual setting where the patient would be seeking the treatment would be a primary care, secondary, and tertiary. So if I were to plan a pragmatic trial, I should be including all the levels of care instead of concentrating on a particular setting as well. So next is the organization. How different are the resources, provider expertise, and organization of care delivery in the intervention group from those available in the usual care? So this will be in terms of interventions. Like, for example, if I were to compare the easiness of endotracheal intubation after a particular muscle relaxant. So in a pragmatic trial, the provider would be anyone from a resident to a consultant. For an explanatory design, they would probably require the provider to be somebody who is experienced with at least 50 intubation and has high success rate and low complication rate. So in organization, we see that the resources and the expertise are close to the usual care and nothing different from that. Flexibility in delivery of the intervention is how different is the flexibility in the intervention from the anticipated from the flexibility anticipated in usual care. So while giving an intervention as such, like if I were to compare a trial drug A versus trial drug B, so if it involves increasing the dose at certain intervals, the flexibility should be as per the treating physician's discretion and not something as per the standard trial protocol. Flexibility in adherence is how the participants are monitored and encouraged to be adherent to the certain intervention. So in an explanatory design, the trial investigators with the help of staff kind of monitor as in how patients are compliant with the investigation, with the intervention of choice. Here, the compliance is not frequently monitored. They are left to the usual setting, as in how the participants would behave in a usual care, irrespective of the trial status. And follow-up intensity, in a pragmatic trial, it's ensured that they are left in their usual care and the data is derived from the health records and the follow-up is not different from the usual care. For example, a heart failure patient post-discharge, we would be calling immediately after 1 week. And then if they are fully optimized after 3 months, 3 months. So if my trial requires like a 2-weekly follow-up, that is going more towards the explanatory design. So something which is happening more frequent compared to what will happen usually. So then the primary outcome. So in a pragmatic trial, it is required that the primary outcome is relevant and clinically meaningful to the participant. So mostly the primary outcomes would be estimating hard outcomes like mortality benefit, whereas explanatory design would have surrogate outcomes. And primary analysis, whoever is randomized is included in the analysis in a pragmatic trial. So an intention to treat analysis is done. They are not looking at per protocol. So there are these 9 domains, and the study is scored from a scale of 1 to 5, where 1 is very explanatory and 5 is very pragmatic. So there is this PRECIS-2 wheel. So in this, the study is actually scored against various domains, and then they are connected to form something like this diagram. So if your overall study is close to the hub of this wheel, this is looking more like an explanatory trial. So if it is widely spread apart like this is more of a pragmatic design. So let's look at a clinical scenario. So you're reviewing a 72-year-old gentleman accompanied by his son. He has a history of type 2 diabetes mellitus, hypertension, and transient ischemic attack. During etiological evaluation of TIA, he was diagnosed with persistent atrial fibrillation and subsequently underwent cardioversion. He has been compliant with his medication and follow-up. Today, he reports of occasional palpitations. On examination, he is hemodynamically stable. ECG shows atrial fibrillation with fast ventricular rate. At this point, his son suddenly interjects and says loudly, "This is because of his caffeine use. I told him to stop coffee." The father looks uncomfortable and embarrassed. The father quietly asks you, "Doctor, does 1 cup of coffee in the morning really cause atrial fibrillation?" So for this, we have this question, does coffee really trigger atrial fibrillation? So to answer this, I looked at this study, caffeinated coffee consumption or abstinence to reduce atrial fibrillation, the decaf randomized clinical trial. So to look at this trial, first we would look into the validity of the study using CAS questionnaire. Then we will go on to assess the pragmatism using PRECIS-2. Then we'll look at the results. So is the basic study design valid for a randomized control trial? Did the study address a clearly formulated research question? Coming to the PICOT statement, the population they included is coffee drinking adults with persistent atrial fibrillation or atrial flutter with a history of atrial fibrillation awaiting electrical cardioversion. The intervention is complete coffee abstinence, comparator maintenance of usual coffee consumption habits, outcomes clinically detected recurrence of atrial fibrillation or atrial flutter lasting 30 seconds or longer, analyzed as a time to event outcome. The time frame was 6 months. Setting 5 tertiary hospitals in US, Australia, and Canada. The study design it's a prospective, open label, multi-center, randomized control trial. So the study did address a clearly formulated research question. Was the assignment of the participants to intervention randomized? They were randomized in 1:1 fashion with stratification by study site to either caffeinated coffee consumption or abstinence from coffee. And the method of allocation, what they have mentioned is by an allocation scheme created by the statistician prior to the start of trial. How the statistician created this allocation scheme was not explicitly stated, and they have also not stated about the allocation consignment as such. So they have assigned the participants to intervention. The randomization was carried out, but is there a possibility of selection bias? We could not possibly come into a conclusion here. And the allocation concealment was also not stated in the study, where all the participants who entered the study accounted for at its conclusion. So here we look at the consort. So they have screened 1,965 patients, excluded 1,739. They came to 200 patients who they randomized to coffee consumption and coffee abstinence, and all the 100 were included in the primary analysis. So they have accounted all the participants who entered the study, and the study was not stopped early. Was the study methodologically sound? This is an open label study. and were the study groups similar at the start of the randomized control trial? We look at the baseline characters. So this is a population with a mean age of around 68 to 70. So here, when we look at the population randomized was 100 and 100, so we don't expect a perfect line in percentages in both the arms. So here the age is around 68 to 70, male predominant. Their BMI was around 30, and most of them were whites. And when we look at the medical history, something which is bothering is the fact that the patients with some structural heart problem like cardiomyopathy, heart failure, coronary artery disease, myocardial infarction, they were little more in the coffee abstinence arm, as we can see here 17 and 21, coronary artery disease 9 and 16, again myocardial infarction 3 and 4. So in total, there were 13 more participants with a structural heart problem in coffee abstinence arm compared to the coffee consumption group. This puts them at a slightly disadvantaged position. And secondly, the history of previous paroxysmal AF, it was 25 in the coffee consumption and 35 in the coffee abstinence. And the symptoms of AF as such, the coffee consumption arms had slightly more symptoms. And there is not much of difference among the type of coffee products which they used. And almost 50% of them were consuming alcohol. And very few were in the harmful use area. And their average baseline coffee consumption was around 1 to 3 cups per day, which is almost balanced on both sides. So looking at this, the coffee abstinence arm had patients with coronary artery disease, cardiomyopathy, and MI, which predisposes them for recurrence. And a total of 13 more participants with structural heart problems were included in the coffee abstinence arm. And there were more patients with paroxysmal AF. So overall, after randomization, looks like there is a slight imbalance, which is not favoring the coffee abstinence arm. So apart from the experimental intervention, did each study group receive the same level of care? They received the same level of care in both sides. And the follow-up intervals were same. And there were no extra additional interventions were given. So because this is an AF study, I looked at the antiarrhythmic use. So there also it seemed to be balancing in both sides. So looking at the overall validity of the study population is well defined, outcomes were well defined, randomization was done, allocation concealment they have not specified. This is an open label study, sample size was adequate, and intention to treat analysis was done. Baseline characters is more imbalance, favoring recurrence in the abstinence arm. So now we'll go on to look at how pragmatic the study is using the PRECIS-2 tool. As you know, this is the PRECIS wheel. So closer to 1 is more explanatory. Closer to 5 is more pragmatic. So we'll look at each and every domain and we'll try and score them in the PRECIS-2 wheel. So first, looking at the eligibility of the participants who are participating in the study. So in a pragmatic design, we try to include as much as patients as possible with the condition so that they are close to the real world data. So what is the problem in recruiting the participants is that like 1 in 10 of the patients who are screened are getting into the study. What are the problems with that? So one thing is, what are the challenges? So one thing is the strategy used to identify and approach eligible patients. So in a explanatory study, which is mostly planned in a tertiary care center, we may not, the consent is taken by a separate person. Like, so what is needed in a pragmatic study is something like a point of care recruitment, where the treating physician itself identifies the patient and enrolls them in the study. And moreover, if the recruitment is done by the same treating person, the patients are more confident with the physician itself and they are more willing for the study. And then patient or the disease under the study. So here, sometimes when assessing eligible population, the elderly patients who may not comprehend the investigations are deliberately said no to participate in the particular study. Then unfamiliarity with the research and research procedure. So not all the general population is educated and they are not well aware that there is a research procedure and they will be randomized. The entire process of randomization and the computer deciding whether you have to go for a treatment arm or a control arm is not well understood among the participants. Then the study design and treatment groups. The reason why most of them enroll in a clinical study is that they might get the treatment and not the placebo or the comparator. So the fact that they are realizing that there is 1 in 50 chance for me to get the intervention may not go well with the participants as such. And then there is practical aspect. To participate in a clinical trial, they have to come more frequently for follow-up, and there will be like wage loss and everything, which and all of these poses important challenges for a participant to enroll in a study. So how do we overcome that in a pragmatic trial? So one is using a wider eligibility criteria. So while assessing a disease or a health status, we have to include as much as patient as possible who has the illness, and there should be no selection based on the likely adherence. There should be no trial run in to see if the patient would actually comply. So as much we could get as much as participants who are close to the real world data. So there should be no selection based on practical difficulties, and belonging to a vulnerable population need not exclude you from a trial. And the other thing is the trial setting is in a different place compared to the place where they would seek their usual care. And the consent and all of those process will be taken by another person who the participants might not be familiar with. This also pose a small threat towards enrollment to the particular study. So how this can be minimized is taking a point of care recruitment, consent taken by the same physician who provides the care, and limiting the number of eligibility criteria also will make more participants come towards the study. And there shouldn't be much additional visit of the patient to the hospital other than the usual care, and as much as data, if it could be captured through health records, electronic health records, that would be making the participant more compliant to participate in the study. So who is selected to participate in the trial? Looking at our study, the inclusion criteria included men or women more than or equal to 21 years of age with sustained atrial fibrillation or atrial flutter, planned or scheduled direct current electrical cardioversion, consumption of greater than or equal to 1 cup of coffee per day sometime in the past 5 years, and willing and able to comply with coffee abstinence or continuation for at least 6 months, and life expectancy of at least 6 months, and willing and able to return and comply with scheduled follow-up visits, and willing and able to provide written informed consent. So I feel the ones which are highlighted in red are more towards an explanatory approach than a pragmatic one. Although they have not excluded much comorbidities, all of those points favor more of a explanatory approach. Looking at the exclusion criteria, they have excluded patients with established allergy or adverse reaction to coffee, who have stated inability to comply with coffee abstinence or continuation, AF ablation in the preceding 3 months or planned in the next 3 months, recent cardiothoracic surgery in the preceding 3 months, pregnancy or desire to get pregnant within the next 6 months, and current enrollment in an investigation or another study that would, another device drug that would interfere with the study, any other criteria which is deemed by the principal investigator. The ones which are highlighted in red are favoring more of an explanatory design than a pragmatic one. So overall, when we look at the study, so there were 1,965 participants who were screened, and 1,739 were excluded, and only 200 were randomized. So this is almost similar to a explanatory design, where almost 90% of the participants, eligible participants, were excluded based on multiple features like unwilling to abstain, recent planned procedure, did not drink coffee, current or prior coffee drinker, but unwilling to drink 1 cup, atrial flutter without history of fibrillation, declined for other reasons, cardioversion cancelled, unable to provide informed consent, and other reasons. So I feel, except for 497, the rest could have been included. So overall scoring them on the PRECIS-2 wheel, I would give some 2.5. It's more towards explanatory than pragmatic. I have not fully given as explanatory because they have included patients with as much as comorbidities as possible. But overall, it's favoring more explanatory. So looking at the next one, recruitment. So in a pragmatic study, they have to be recruited like at the point of care itself. So how are the participants recruited into the trial? So here they have recruited from 5 tertiary hospitals in US, Australia, and Canada. They have not specified if that was done as a part of their usual care or if they had issued public advertisement, as in if anyone is willing to participate in the study, or send postal letters to the eligible participants. So there is still an unsureness, so I have not graded the recruitment here. Next is setting. So in setting, in a pragmatic study, this should resemble the usual care setting where the patient would probably get the treatment for a condition. So here the disease in question is atrial fibrillation. And where all can a participant get the treatment for atrial fibrillation? One, they would be detected in primary care, but this they can get treated in secondary care, cardiology specialized hospitals, as well as in tertiary care hospitals. Here in this trial, we looked that the patients are recruited from 5 tertiary hospitals in US, Australia, and Canada. No secondary hospitals or cardiology specific clinics were involved. So this is again moving more towards explanatory setting. So I've given 2. So next we look at organization. So in organization, we look at what are the expertise and resources required to deliver the specific intervention or the usual care. So as I said earlier, when we are assessing some uh, a study like success of ease of endotracheal intubation in patients where we are trying with different muscle relaxant, we probably require the person who is doing the intervention to be someone who is at least experienced with the intubation so as to get the high rates of success and low complication. So that is the kind of explanatory outlook. In a pragmatic trial, whoever can do the possible intervention would provide the particular care. So it is applied to all full range of practitioners in the clinical setting, regardless of their expertise, and only ordinary attention to dose setting and side effects. Whereas in an explanatory trial, who delivers a particular intervention is looked at carefully. Like they should be the ones with high rates of success and low rates of complication. And the settings also would be like to provide the high delivery, high quality care and um, low complication rates, and expertise and resources to deliver the comparator. So in a pragmatic trial, the usual care with their usual providers will continue. Whereas in an explanatory trial, the comparator intervention is standardized so that there is a maximum chance of detecting whatever benefit that could be possibly achieved in a intervention. So the comparator level also it is standardized. So what happened to our study? While looking at the task of screening and selection of participants, they have left that to the principal investigator and the staff. I feel they would have required some additional personnel, but then they have not disclosed. Looking at the baseline visit, they have documentation of lifestyle, pre and post cardioversion ECG. Normally, for a patient who is going to undergo cardioversion, they would require a pre and post cardioversion ECG. So this is more pragmatic. Follow-up phone calls at 1, 3, and 6 months. Normally, a patient with atrial fibrillation here would have follow-up in 1, 3, and 6 months, and they would be probably visiting the hospital. So having this phone call element is going more towards an explanatory approach. And device used for detection of AF. So they have detected it from ECG strips, mobile devices, and Apple Watches, which were already owned by the participants. So they have not mandated that everybody in the study should own a specific device. And this is looking more towards pragmatic. And the recurrent AF documentation, ECG or ambulatory ECG monitoring, if patient reports recurrence or unsure of recurrence. So this is also more pragmatic. The intervention and the comparator, coffee consumption as such, they have not advised to take a specific dose or a specific brand for coffee. So that is left to the participants itself. So this is more pragmatic. So overall, except for the except for the follow-up phone calls, this is leaning more towards the pragmatic approach. So I have given a score of 4. Next, moving on to flexibility in the delivery of intervention and the usual care. So in a pragmatic trial, the investigators are given the authority to provide the intervention as per their assessment. Whereas in an explanatory trial, there are strict protocols and the investigators are required to adhere to the protocols. So whereas in a comparator also there is, in a pragmatic trial, it is the usual practice or the standard of care which is available in that setting. In a explanatory trial, the they would be mostly placebo controlled or the gold standard, which is also um, under the strict protocolized situation. So how should the intervention be delivered? If in the coffee abstinence group, if they are allocated to coffee abstinence, they were encouraged to completely abstain from coffee, including decaffeinated coffee and other coffee containing products. And if they are allotted to caffeinated coffee consumption group, they are encouraged to drink at least 1 cup of caffeinated coffee or at least 1 espresso shot and continue the other caffeine containing products as per their usual lifestyle. They were not asked to intentionally increase or decrease the coffee consumption. So because there's an element of you do not drink the coffee and you drink at least 1 cup that is involved, I have just reduced the score to 4. Next, we'll move on to flexibility in adherence of the intervention as well as the comparator. So in an explanatory trial, the participants are ensured that they are strictly complying to the strategies. So if they are totally compliant to the strategies, they are included and sometimes they are excluded also. But here, whoever is randomized is included and there are no extra measures like assigning a specified staff to make sure that they are very strictly complying to the strategy or not. We do not have that provision here in the pragmatic trial. So among the providers also, there is no extra staff or something to monitor the practitioner who is providing the intervention, whereas the usual care. Whereas in an explanatory trial, they are strictly adherent on this manual of procedures and the trial protocol. So what happened to our study? So these patients had phone call follow-ups at 1, 3, and 6 months, where they are assessed as compliance with the allocated treatment, consumption of coffee and alcohols, if they are symptomatic for AF or not, and their ECG strips and the data from their watches are analyzed to see if they had got AF. Then they were also looked at for these adverse events, and the vital status was also followed up. So the follow-up phone calls seem to be going more towards the explanatory approach. So I have reduced 1 and I have given a score of 4 here. So now looking at follow-up. So how stringent is the follow-up strategy? So when we look at a typical explanatory trial, the participants are followed up at regular intervals at 2 weeks, 4 weeks, and data is collected regarding to the trial at these follow-up intervals. And if there is any adverse events, that is also captured in this frequent follow-up. Whereas in a pragmatic trial, they are randomized at visit 1. Sometimes they have a follow-up visit. Sometimes they may not have the follow-up visit. So what is the downfall of that is that adverse events or the recurrence of an event might not be strictly captured in this setting. So for follow-up intensity, so the pragmatic trial will have as close as to their usual care, and an explanatory trial will have a stringent follow-up visit with more frequent visit and extensive data collection during that time. How closely all our participants followed up? These are telephonic contacts at 1, 3, and 6 months. 1, 3, and 6 months were okay, but the mode of follow-up is looking more towards more towards explanatory. So I've given a score of 4. So next we look at outcome. So primary outcome in a pragmatic trial. This should be a clinically meaningful outcome to the participants. So for example, the study involves atrial fibrillation. how much of abstaining or taking coffee prevent a death or prevent a hospitalization. That would be more meaningful to the participant as compared to a device detected atrial fibrillation for lasting for 30 seconds or so. So that outcome looks more like an explanatory outcome. So the outcomes in explanatory trial are to be known to be like a direct or immediate consequence of an intervention. Like if you are using antihypertensive, this much of BP reduction at 6 weeks, 12 weeks, those kind of direct or an immediate consequence of intervention are looked at mostly in explanatory trial. This would be, some will actually look at mortality benefit, but the immediate or direct consequence is mostly looked at in explanatory trial. And this also involves central adjudication of outcomes, whereas that's not needed in pragmatic trial. So what decides, as in what outcome do we fix for a trial? So few things we look at are mortality benefit. So does this intervention actually prevents mortality? Then the quality of life. Do the patients have a better quality of life when we provide the intervention? We also look at the resource and the costs which are involved. Pathophysiological manifestation, this is a more of an explanatory design. And then we also look at adverse events. We also consider who are the stakeholders involved in the particular intervention as such, what are their preferences, the effect modifiers, do the patient or the disease or setting possibly modify the treatment effect, what are the routine measurements and is it measured and how was it measured, and what kind of outcomes did the previous type of studies measure. Considering all of that, and we also consider if it affects the generalizability, is it feasible to measure, are the measures sufficiently valid and precise, and then decide on the primary and secondary outcomes. So when we look at this outcome, number of participants with first confirmed clinical recurrence of AF or atrial flutter or a device detected recurrence lasting for longer than 30 seconds analyzed as time to event outcome. This is mostly looking like a surrogate outcome. This does not specify if there is a mortality benefit or not. It does not look into any heart failure related events like hospitalization, heart failure exacerbation, MIs, and there is when like this may not be clinically meaningful. That patient can still remain asymptomatic, carrying on with their day-to-day activities with the device detecting some atrial fibrillation lasting for more than 30 seconds. So I feel this is more of a surrogate outcome. Secondary outcomes which they looked at are recurrence of atrial flutter and atrial fibrillation separately, and adverse events like MI, stroke, heart failure exacerbation, emergency department visits, hospitalization, and death. So this looks more explanatory, so I gave a score of 1. So we look at primary analysis. So pragmatic trial usually does intention to treat analysis, where all the participants who were randomized are analyzed in the end. Whereas explanatory trial, they also perform intention to treat analysis, which will be supplemented by a per protocol and restricting only to the patients who are complying to the investigation as such. So to what extent are all data included, intention to treat analysis was done. So for that, I gave a score of 5. So while connecting all the dots, we get this figure. So do you also feel the same? How many of you feel the same, or is there some difference of opinion we have? Any difference of opinion compared to what I scored? No. Okay, we'll move on. So this is the total picture. So if it was more pragmatic, we would get it close to 4 or 5 here. Then we move on to our CAS checklist and see what the results are. So where the effects of the intervention reported comprehensively. So this for sample size, they assumed a recurrence rate of 50% of atrial fibrillation post direct cardioversion, and assuming a two-sided alpha of 0.05 and a power of 80% and a loss to follow of 10%, they estimated a sample size of 200. They also assumed there is a hazard of 1.63 times, have not specified towards which direction. Is it towards the coffee consumption group or towards the abstinence group? The outcome measures, I felt these were surrogate outcomes. And the outcome analysis was a time to event analysis, and they used Cox proportional hazards regression models to formally analyze the primary endpoint with pre-specified adjustment for study site. For secondary endpoints, for atrial flutter and fibrillation recurrence, they used Cox hazard regression models, and adverse events were compared using chi-square tests. So what are the potential biases? I felt there could be reporting bias in terms of coffee consumption in both sides, in abstinent as well as coffee consuming groups. And because the allocation concealment was not stated explicitly, and the study being an open label study, is there a selection bias? That is another concern here. Looking at the results, so this is the Kaplan-Meier curve. So here we see the days of follow-up in the x-axis and the probability of recurrence of atrial fibrillation in the or flutter in the y-axis. So at 180 days, the coffee consumption group had some 47% recurrent atrial fibrillation or flutter, whereas the coffee abstinent group had 64%. The hazard ratio is 0.61. So which means that the coffee consumption group had 39% less hazard of developing an atrial fibrillation compared to coffee abstinence group. So this is actually favoring usual coffee consumption. And and this effect can be as low as 11% to as high as 58%. And the confidence intervals are between 0.42 and 0.89, not crossing 1, with a p-value of 0.01, which is statistically significant. And there is no differential loss to follow up when we look at the number at risk. So if we see like when did 60% of the participant get atrial fibrillation of flutter, which means when did they get 40% of atrial fibrillation? When you look at coffee abstinence group, they got it at 30 days, and when you look at coffee consumption group, it's close to 90 days. It's where the 40% of the events were reported. So we can also infer that coffee consumption kind of delays your on the recurrence period by around 2 months, which is like 60 days. So when we look at the differential coffee consumption, so baseline, they all started with same amount of consumption. One group was asked to abstain. So we can see that still few people are consuming coffee and they are not really compliant to the investigation. So this is what that has been stated in the pictures. Looking at adverse events, there's not much of difference. Like when we look at the emergency department visits, coffee abstinence had more emergency visit. While looking at hospitalization, coffee consumption had more. They differed by 1 to 2. And there were no deaths in the study, and 2 of them had MI. Was the precision of the estimate of the intervention or treatment effect reported? They were reported, and confidence interval also we looked at. So at the start of the study, I was saying there were like 13 patients with structural heart disease who were more in the coffee abstinence arm. So this study already assumed that 50% of the patients would anyway recur post cardioversion. So my point is that did that 64% include all the patients with the structural heart disease? So did this group with the structural heart disease get more events because of the baseline imbalance? So that is one concern with the study itself. So do the benefits of the experimental intervention outweigh the harm and cost? So I personally believe that because of the baseline imbalance, the study had proved that there is more harm with coffee abstinence. But if we have to take the results of the trial as such, we would get a number needed to treat of 5.8. So overall, calculating the cost to prevent one atrial fibrillation, assuming that the results of the trial are valid, would be 13,500. Can the results be applied to your local population in your context? So looking at our population, this is the data from Garfield AF registry. This is the data from Indian patients. So when we look at our patients had low BMI compared to the 30 BMI, which is in the study. And our patients are slightly more diabetics. And when we look at their coronary artery disease state is also slightly more because they're more diabetics as such when we compare to the global population. Plus, when we look at the data on the risk factors, our patients have more of valvular heart disease, which is more than the global data. And with the lean body mass, so I feel most of our atrial fibrillations which are captured are in that valvular heart disease predominates. So our patients have more of this substrate problem than atrial fibrillation itself. So when we look at the difference between paroxysmal and permanent bar persistent atrial fibrillation, so paroxysmal ones have this ectopic focus, which are mainly trigger driven, like alcohol, coffee, kind of triggers most of these paroxysmal AF than the ones with permanent or persistent AF. Permanent or persistent AFs have more of a substrate problem. And the population in India would have more of rheumatic heart disease with the valvular heart disease going into AF, who will have more of substrate problem as compared to the Western population. So my inference is having a coffee or not may not make a change when your problem is mostly going to be substrate. So our population demographic characters are different, and as well as the disease in question is also slightly different compared to the global population. And are the outcomes important to your population? This is not something like a mortality benefit. It's still a surrogate outcome. So would the experimental intervention provide greater value to your people in your care? I don't believe so. And coming back to our case scenario with the father, son, and his usual coffee consumption, I would probably advise him that uh, continuing his usual coffee would not do additional harm to the already existing factors, and I would evaluate for his baseline status and optimize his comorbidities. And the applicability to our persistent AF population is limited. And our persistent AF, as I said earlier, is predominantly substrate driven than a trigger driven process. And post cardioversion recurrence is common and it's multifactorial. So now coming to the place, like we looked at pragmatic trials. So where do they find its place in India? So when I looked at the articles, there were two articles. One is the Empower Heart Project, which is a nurse-led project which was done predominantly in Andhra Pradesh. This was a cluster randomized pragmatic trial. The other one which I looked at was done in CMC itself in the psychiatry department, where they used intramuscular olanzapine versus haloperidol plus promethazine. So these are the two trials which I found here. So looking at pragmatic trials, one large registry is the Swede Heart Registry. So this is mainly related to cardiovascular diseases and the intervention. So this is from Sweden. So there are multiple hospitals which are networked to this, and they have this electronic health record. So as soon as the patient is entered into the hospital, the patient is enrolled in at least one or two trial, and they take embedded consent, as in consent to the hospital as well as consent for the studies. And before doing a procedure, they ask a verbal consent and randomize the patient to either of the arms. And as everything is linked to their electronic health record, they could easily retrieve their data and finally publish the trials. So this heart registry has published around 395 trials as such when you do the PubMed search. So where do we stand in the spectrum of pragmatic trials? So our population, there is huge disease burden with large patient volumes. There's a mix of public and private healthcare, and there is rapid digitalization and resource variability. But what are the challenges we encounter is one is the limited EHR integration, and the healthcare system is fragmented. And our public do not understand much about randomization, consent, and clinical trial. If you could possibly explain, they would all assume that they're being considered as guinea pigs. And there is also follow-up challenges because once they are better, hardly patient returns to the hospital unless and otherwise they are motivated strongly. Plus, there are superstition and inherent beliefs. So all of this will limit the conduction of a pragmatic trial as such. So is there a scope? Yes, there is definitely. We could try out all of this, but there is a long way to go. So this brings to the end of today's talk. To sum up, initially we started about the research continuum. We looked at what explanatory trials are and what pragmatic trials are. And with the help of an example, we looked at how pragmatic the decaf trial is. And through the example, we looked at various aspects which would determine the pragmatism in the trial. And finally, we looked at where do we stand as a country in respect to the conduction of randomized control trial. So thank you. And these are the references. And I would like to acknowledge Tambu sir and Vignesh sir for helping me with this presentation. Thank you.